Yeah, so today I'm going to talk about some of the clinical advantages of using ultra high field, and I have no disclosure. So yeah, this is an overview. I will just review basically some of the most common neurological diseases where you can actually take significant advantages in using the ultra high field and the potential utility in terms of patient prognosis of this ultra high field data. So just a brief introduction. The first MRI scan, was acquired at the end of the 70s, and it was on 0.6 Tesla field strength. And then in the 80s, there was the initial application of the MRI imaging for clinical reasons in medical diagnostics. And then the first ultra high field human brain image was acquired in 1998, and since then there was a lot of development, and the first MRI system that was FDA approved for clinical scans was introduced in 2018. So I will start with multiple sclerosis, which is the most common immune-mediated myelinating CNS disorder. And this disease leads to, unfortunately, a lot of neurological issues to these patients who are also relatively young. And in fact, it's the leading cause of non-traumatic neurological disability in young adults. And the diagnosis is primarily clinical, but MRI plays a critical role in this disease, both in terms of diagnostics and in terms of treatment and prognosis. In fact, here I reported a FLAIR image where you can see some of the white matter lesions that are characteristics of multiple sclerosis. And the radiologists, they use these lesions to classify the patients, and based on the final classification, the treatment is tailored based on that. So MRI can play a critical role also for the actual treatment for the patient. And it's also very important, especially at ultra high field, for the investigation of the pathophysiology of this disease, since there is still it's still unclear what are the main pathophysiological mechanisms underlying this disease. So one of the main advantages of using ultra high field in multiple sclerosis is the identification of the lesions. And in fact, 7 Tesla MRI allows the identification of lesions that are not easily detectable on the clinical and high field strength. And this is important because, as I mentioned, even small lesions can actually provoke huge symptoms to the patients. And in fact, the location of the lesion is very important. It's probably the most important factor for the actual symptom of the patient. And more recently, also the detection of lesions in the gray matter was found more easily on 7T compared to 3T, where in fact it's actually usually impossible to see gray matter lesions, but on histology you can actually see these lesions, and in fact these lesions now are considered important in the diagnostic process because these are in the gray matter, and therefore they play a major role in the symptoms of the patients. Another important factor is related to the differential diagnosis. So sometimes, unfortunately, these lesions are very similar to other incidental lesions that you can find in people, even healthy people that might have these lesions, but they have no symptoms. But you need to be able to understand if this person is developing multiple sclerosis or if it's really just an incidental lesion. So there are some markers that allows you to better understand whether these can be more likely multiple sclerosis lesions rather than incidental lesions. And one of these biomarker is the central vein sign, which is very evident on 7 Tesla MRI data because of the susceptibility effect, which is increased at 70 MRI, and instead on 3 Tesla MRI, it's usually less evident. And another element is the paramagnetic ring, which is also easily detectable, more easily detectable on 7 Tesla MRI data, and instead it's not usually visible on 3 Tesla data. And it's basically this ring surrounding the veins, as you can see, and it's thought to be related to the actual pathophysiological process of extravasation of inflammatory cells that then induce the damage to the white matter. And this is again related to the higher susceptibility that you can get with the 7 Tesla MRI. This is an example that we acquired at USC. And as you can see, the picture of the veins is significantly better at 7 Tesla compared to 3 Tesla MRI. Another important clinical application of 7 Tesla MRI, ultra high field MRI, is for cerebrovascular diseases. And stroke, of course, is the leading cause of mortality and disability worldwide, and is therefore considered a major cerebrovascular disease. And the diagnosis in stroke is also usually primarily clinical, but CT and MRI plays a critical role, both in terms of diagnosis and also in terms of the treatment, the actual treatment. In fact, they allow you to understand to better define the area of the stroke lesions, and therefore to define the type of treatment that you want to prescribe to the patients based on this data. And the most commonly used MRI techniques for stroke are diffusion, MR angiography, and recently also T1 space is going to play is playing a role in the depiction of the smaller arteries. And as I mentioned, one of the major advantages of the ultra high field is a better characterization of the stroke lesions, which is important for the clinician in order to understand the underlying cause of the stroke and therefore tailor the therapy based on that. Because, as you know, we can have two types of strokes, hemorrhagic or ischemic, and the treatment is completely different. And in ischemic strokes, you also don't want to increase the chances of bleeding in these patients, and therefore it's good to know the biological characteristics of the stroke lesions for this reason, for treatment reasons. And then also in terms of contrast between the white matter hyperintensities, the white matter and the stroke lesions, ultra high field MRI have shown the opportunities to better depict the actual focus of the lesion and to differentiate it from the white matter hyperintensities, which can be very prominent in these patients and can therefore sometimes obscure the actual stroke lesions. Another important advantage of ultra high field is the detection of the microbleeds, which is significantly improved at 70 MRI, and this is again due to the increased susceptibility effect. And in fact, you can see that many lesions are actually not visible at 3 Tesla, but becomes visible at 70, and this is important also for the prognosis of the patient. And finally, something that is becoming more and more important in terms of clinical applications is the identification of these cortical microinfarcts that actually are believed to play a critical role in terms of prognosis of cognitive dysfunction and also potentially of motor dysfunction, because these are usually not visible at 3 Tesla MRI, but when they become visible at 7.3, they allow you to better define the risk of the patients and therefore tailor the treatment and therapy, because these patients are also undergo chronic therapy, and therefore it's important to tailor that based on the risk that you can estimate from the images. Then I mentioned also the T1 space that Dr. Wang's group developed, and you can see here it's very useful for the detection, especially of the lenticulostriate arteries, as you can see. and more numerous branches are visible at 7, become visible at 70 compared to 3 Tesla. And this is a critical area because these vessels are, since the course is perpendicular to a major vessel like the MCA, this vessel supported a big stress, mechanical stress in terms of blood pressure that is changing due to the direction. And so these vessels are very prone to break and to lead to hemorrhages. And therefore, it's very important to be able to image this vessel because sometimes you can detect something like this, which is a small microaneurysm, silent. So you don't know this patient, of course, didn't have any symptom at this time because the aneurysm was there, but it's a silent pathology, basically. And this, of course, it's playing a double role. On one hand, you know that this patient has a risk, but on the other hand, you don't know how to treat this because currently it's very hard to reach this microaneurysm without operating the patient, so without performing without performing surgery. So of course it's good to know that this patient has a microaneurysm, but in terms of therapeutic options, is currently still something that there's not really something that you can do in this situation. And also in terms of time of flight, MRA, there is an increased visibility of arteries at 70 compared to 3 Tesla, and this is again mostly visible in the lenticulocyte arteries area and in the insula. Another area where actually you can see much better, actually you can see the vessels is the white matter, the centrum semiovale. At 3 Tesla, you cannot really see these small perforating medullary arteries, which usually are not responsible of stroke. These are very small arteries surrounded by white matter. But these are thought to be important because they might constitute the main pathway of the so-called lymphatic system, which is recently become very important and popular in neurodegenerative disease field because it's thought to be responsible of clearance of waste products. And so these vessels are surrounded by a small space where the interstitial fluid and the CSF are drained and they clear out the drain from waste products. So it's important to image these vessels at 70 to better understand the mechanism of drainage of this system. And in fact, we can actually image these so-called perivascular spaces. So these spaces that surround these vessels in the white matter. And this is an image at 70 that we acquired at USC. And then we applied our segmentation algorithm for the segmentation of the perivascular spaces. And therefore, we are able to quantify these major pathways of the lymphatic system and try to understand how they are able to either be used as a biomarker for the development of cognitive dysfunction, or to better understand how they actually change through time and under different conditions. So 7 Tesla MRI definitely facilitates the quantification and visualization of these perivascular spaces. And this is another study where we basically showed how much the resolution is important, and for the quantification of the perivascular spaces. And here you can see at 70 you can actually differentiate much better each perivascular space from each other. Instead, at 3 Tesla, the quantification is less accurate because some of these are considered only as one element. I mentioned the neurodegenerative diseases, and I will talk a little bit about the two most common neurodegenerative disorders, which are Alzheimer's disease and Parkinson's disease. And in both of these pathologies, the diagnosis is mostly clinical, but also based a lot on the MRI data. So ultra field MRI can play a critical role in neurodegenerative diseases because, as was mentioned earlier, it allows to better visualize and the subregions of the hippocampus. So like in this case, we were able to image the fingea and also the digitation of the hippocampus. These are very important details because the hippocampus is the region where this disease, Alzheimer's disease, is thought to start, but it does not affect the whole hippocampus, but it's specific for certain regions. So being able to image these subregions is important for in terms of research purposes to better understand how this disease evolve and which regions are those that are more involved in pathology. We also recently demonstrated that blood-brain barrier breakdown is important for an important biomarker which leads to cognitive dysfunction contributes to cognitive dysfunction, and is related to APOE4, which is a genetic risk, the major genetic risk factor for Alzheimer's disease. And we were able to acquire the first DCE images, dynamic contact enhanced images, that allows you to quantify the blood-brain barrier permeability in humans. And as you can see at 70, the spatial resolution is significantly improved, and also the SNR in the white matter. And also in terms of T1 mapping, the quantification of the blood-brain barrier relies on the T1 mapping, and also, as you can see in this example, the T1 mapping obtained at 70 is, in terms of spatial resolution, is much better compared to what we can have at 3T, and also in terms of coverage, because at the same time, with the same time scanning, you can get much more coverage of the brain. These images were acquired by Dr. Papas at USC. And then another element important in neurodegenerative diseases is the white matter microstructural changes. And at 70, we demonstrated that basically you are able to get a better depiction of the white matter tracks, and to reduce also the partial volume effect, which allow you basically to get better and more accurate quantification of the actual tracks, as well as improve the detection of some tracks that otherwise would not be visible at 3 Tesla. And this is another example where there are some white matter bundles that will not be visible at 3T, but become visible and quantifiable at 17. Also for Parkinson's disease, the diffusion MRI at ultra field can play a critical role. In fact, for Parkinson's disease, one of the treatments that is life-changing for this patient is the deep brain stimulation. Unfortunately, this surgical treatment is not always successful. And in this study, Planting et al. Demonstrated that a better localization of the subthalamic nucleus, which is the nucleus that the surgeon needs to treat for the stimulation of this nucleus in order to improve the symptoms of the patient. It was demonstrated that using diffusion to better identify the motor part of the subthalamic nucleus, it's actually significantly improving the outcome of these patients after the surgery. Because sometimes after the surgery, the patient has no improvement in symptoms, and this is usually indicative of the fact that the probe was not placed in the right position. And the ultra field, it's actually a promising tool to better perform these tasks, because it improves the localization of the motor part of the subthalamic nucleus. Also for epilepsy, there are some applications of the ultra field MRI, and the epilepsy affects 50 million people worldwide, and unfortunately 30% of these patients have disabling seizures, which are unfortunately not responsive to treatment. And MRI is useful to understand what's the cause of these seizures, especially in patients with focal seizures. So these patients usually have a structural abnormality that leads to the development of the symptoms. But unfortunately, sometimes this structural abnormality is very small and it's not detectable on MRI. But it was noted in several studies that focal cortical dysplasia, FCD, and medial temporal sclerosis become more visible at 7 Tesla. And actually, this changed basically the prognosis of some of these patients because they were surgically treated, trying to remove this altered tissue that were identified on MRI, and then they basically recovered from symptoms. So that was life-changing for these patients. And also sometimes, as I mentioned earlier, these symptoms can be related to microhemorrhages. And so, as I mentioned, the 7 Tesla MRI allows you to identify more microbleeds, and therefore also allows you to better understand if there is any of these microbleeds that can lead to the development of the seizures. Unfortunately, these microbleeds are not treatable, but you identify at least the cause of the seizure, and also for the white matter lesions that sometimes can cause seizures. In terms of neuro-oncology, one of the main applications has been of ultra field MRI has been for the identification of the microadenomas and the microvasculature. And in fact, this is an example of a patient that we scanned at USC a few years ago, where you can basically see that at 70, the microadenoma become evident, which instead is not really visible at 3 Tesla and 1.5 Tesla. So this patient basically got a diagnosis based on ultra field, and therefore the treatment. Also, in terms of MRS spectroscopy, the ultra field have shown the advantages of improved classification for the glioblastoma. And in fact, this is an example where basically this biomarker of 2-hydroxyglutarate was identified at ultra field, but was not visible, quantifiable at 3 Tesla. And this is a biomarker of specific mutation status of the glioblastoma, and this is very important for the prognosis of the patient, because the patient with a specific mutation status have a completely different prognosis compared to patients with another type of mutation. And therefore, it was critical to know this just based on the MRI, because the treatment was basically applied right away based on the type of tumor that this patient had. And then there is also, as I mentioned, more visualization of microhemorrhages that in tumor patients are indicative usually of metastasis. And therefore, if you are able to identify these microbleeds, you know that this patient basically has a recurrence or has metastasis. And so the treatment is completely different in this case. Like you have to start the chemotherapy or the radiation therapy. And therefore, being able to identify this can be life-changing for this patient. Of course, there are major challenges that have been discussed during this earlier this morning, and one of these advantages is, of course, the immunogenesis is 0 and B1, although there are some techniques that have been described today that can significantly improve these challenges, and also motion artifacts. This is something that several radiologists usually complain about, because of course the fact that you get a better spatial resolution, it significantly increases also the motion artifacts because of that. So sometimes makes some lesions less visible. But on the other hand, there are some procedures and techniques that can improve this these artifacts, motion artifacts, and some of them have been described today. And then, of course, the fact that some biomedical implants have not been tested yet at 70, although also this is going to improve with time. And we recently also scanned actually a patient with bilateral total knee replacement, and everything went well. And we provided also some guidance on how to handle these type of scenarios, clinical scenarios, and which type of risk to evaluate, and how to decide what's best for the patient, of course. And yeah, these are the people that contributed to some of this data. And thank you for your attention, and I'm happy to take any questions.